Affection, I would like to introduce Dr. Rajam Iyer, who is well known, and she is a pulmonologist and a palliative care consultant. Having both under her banner is really good, and it's a privilege to have someone like her to take us through the topic. And as we were mentioning before, respiratory and pain play a very big role. Breathlessness and pain are the two main important symptoms which someone has to be able to deal to say that they are able to manage a palliative care patient. So we have the best person to take us through today. She is a practicing physician in Mumbai at both Bhatia and Hinduja hospitals. And she has added many qualifications to herself, both national and international. And she has umpteen presentations and publications she's done during her career. And it is very vast and wide, both clinical symptoms and presentations and patient compliance and various, and she's also been part of guidelines and treatment for asthma, which is one of the big chunk for a pulmonologist. So we have one of the best persons to take us through respiratory symptoms. Thank you very much for doing this for us, madam, and the floor is yours.
Ma'am, you're muted.
I have seen you so often that I don't think, you need to be hearing me at all. I think you can really take this class from here on. It's such a nice feeling to see a familiar face. Thank you for that introduction, and thank you for this opportunity, Pallium. I'm sorry, I might be a bit distracted today. I've had a horrible day. And also I've had I'm currently having two very bad patients who are constantly messaging regarding decision for admission and etc. So I'm a bit distracted and a bit upset about how my patients are. But anyway, I will try to focus on this. So good evening. I know all of you have finished a day's work and you all don't want to hear uninteresting things. So for that, I will also request you that during the lecture, please interrupt so that we can interact and so that we can make it interesting for both you and me. And just correct me if I'm wrong, Shri Priya. This batch is the one which is having the foundation course and they finished 12 like talks. Is that right?
Yes, ma'am, absolutely.
Okay. So then I should stick to this particular presentation. So without wasting much time and I'll just start sharing my screen. So please keep the questions and the queries coming in the chat. Between me and Shri Priya, somebody or the other will keep looking at it, and it's best to interrupt at the point you don't understand so that we can clarify and take it from there. Okay. So today, like Shri Priya said, we are going to talk on respiratory palliative care, and it's as they mentioned, I am a trained palliative care physician, and somewhere around 5-6 years ago, because of a personal tragedy, I kind of shifted gears and I got trained in Pallium India as well as the IPM for my fellowship and did my master's diploma from Cardiff University in palliative care. And I'm really, really glad that I managed to change this gear in the middle of my life because it has really added value to my career as a physician. So today we are going to focus on respiratory palliative care. And one of the first things that I need to emphasize to all of you is the need to introduce and integrate palliative care in non-cancer conditions. Historically, all of you know that palliative care began for patients with advanced cancer. And unfortunately, that tag still sits along. So the problem is that everybody thinks, including doctors, that palliative care means it is for cancer patients and palliative care means for patients who are dying, that is at end of life. And the whole point that we, along with institutions like Pallium India, are trying to do is that palliative care is need-based. It's for all. and it is important to address for not just cancer patients, but also non-cancer. So if you see this slide and chart, it very clearly shows that India adds about 1 million cancer patients every year. But look at the amount of patients who suffer from the non-cancer or the non-communicable diseases like COPD, ILD, cardiorespiratory diseases, diabetes, stroke, dyslipidemia, hypertension, including tuberculosis. So we are a nation where we have so many people affected by lifestyle conditions. And between you and me, we all know that we cannot cure diabetes. We cannot cure blood pressure. We cannot cure a patient who's had a MI. We can do other things to make him live. But these are the conditions which can only be controlled. They cannot be cured. And infectious diseases probably are the only conditions which can be cured. So as doctors, you and me are probably able to cure only 1/3 of the diseases, while the other 2/3 needs hand holding. So if you see the chart, almost 50% of Indians are affected by these non-cancer lifestyle conditions, which are chronic, incurable, probably often controllable. Therefore, it brings us to think that these are the patients who suffer a very prolonged period of time with high symptom burden. And therefore, we need also the numbers are rising. So the estimate of TB, as you know, despite it being a fully curable disease, tuberculosis with its XDR, MDR, totally drug-resistant tuberculosis is now a cause of national worry. And we are in the process of actually writing up guidelines for tuberculosis and palliative care. Incidence of COPD has also increased because of domestic air pollution as well as outdoor pollution. Interstitial lung diseases are also on the rise. So India contributes to the global burden of respiratory diseases by 1/3 of the illnesses. So 1/3 of the world's respiratory conditions is in India. And therefore, it becomes very important to see how are we improving quality of life of these patients where we are not able to offer cure. And as I was telling you, if you see this graph, I'm sure in the last 12 sessions, you all must have seen this graph. Today, the focus is the graph C, where our patients suffer a very high symptom burden for a very prolonged period of time. For example, a patient of COPD is diagnosed at the age of 60 or 65 and continues to live a poor quality life till death for about 10 to 15 years. Every time we doctors and we pulmonologists see, it is only during this acute exacerbations. We don't know how these patients function at home. Are they eating? Are they sleeping? Are they able to self-care? What is their mental level? So this is something unfortunately not even included in our training and beyond the purview of a pulmonologist who's busy in his clinic seeing 50 patients, whether his chest has improved, his breathlessness has improved, his cough has improved. And unfortunately, that's where our case history ends. These kind of people are the ones, imagine, who are housebound, probably room-bound, strapped to oxygen, breathing at a rate of 20 to 30 beats per minute, and their full life is in that room. So just imagine the frustration that that patient has and the caregivers have. And there's so much suffering that is not even budgeted for, and nobody even inquires. So patients with organ failure, like congestive cardiac failure, COPD, interstitial lung disease, chronic renal disease, chronic liver disease, all these patients keep chugging along in and out of hospitals, in and out of doctors, and not just them, even the caregivers lead a poor quality life. Therefore, it's very important for us to focus on non-cancer diagnosis, because when a doctor diagnoses a patient to have cirrhosis, COPD, ILD, CKD, it is not perceived as a life-limiting or a life-threatening illness. So if I diagnose a patient to have lung cancer, the impact that that patient has on how much time do I have to live? Oh God, what I have to do? My life is over. That impact does not come when you diagnose a patient to have COPD. Because even the doctor doesn't tell the patient that it is a life-limiting and life-threatening illness and there is no cure. So it's important for us to educate the specialists and the general practitioners about the need and the reason why we need to integrate palliative care in all specialties. Because if you see any chronic lung disease, you will also realize that it is like falling off a skyscraper. As a trained healthcare professional, You know the trajectory of a COPD. You know the trajectory of an interstitial lung disease. Therefore, you should be the one responsible to have unhurried, sensitive, timely conversations as the patient is falling off the chronic disease skyscraper. Very often doctors wait till the patient is almost at the first floor and say, sorry, now he's very critical, these are the only options or we cannot do anything. It is our onus to foresee and foretell so that we give the patients the time and the bandwidth to process and analyze what their disease is. How are they going to progress? They should know the natural trajectory of their illness so that they have the time to think what should be done and not be done in an emergency. Because the manner in which you land depends on the way you fall. So if you have not prepared at all, it's going to be a really bad thud. But if the patient is prepared, if the family is expecting the emergency, they are in a better frame of mind, even though they will be stressed. The timing of these discussions cannot be outside the ICU where the emotional stresses is so high. It has to be done in a much planned, much better way so that it's easier for our patients. Therefore, we actually like to integrate palliative care as early as possible so that it is along with the curative phase. As the curative options fall, the palliative care options kind of take off. And we also get introduced as a part of the team member or another member of the team so that the patient doesn't feel abandoned, that now pulmonologist's job is over, now you can go to the palliative care physician. That should not be the case. It should be a smooth transition. It should be a shared care. It should be a team management for the patient because there's so much going on for the patient and the caregivers. The other beauty about palliative care is also that we look after patients at the end of life, and we continue to support the family after they've lost their loved one. So there's such a holistic, multidisciplinary care, which does not require high gadgets, high-tech instruments. It actually requires a compassionate, kind human being. So very often pulmonologists feel that referring to palliative care is losing hope. It's like giving up. So therefore, this surprise question was actually researched in England, where the timing for referral, which was crucial, was analyzed. So if you have a patient sitting in your OPD, in your own mind, if you're able to think, will I be surprised if this patient is not alive in the next 1 year? And if the question gives you an answer in your mind as like you will not be surprised, that is the time to try to introduce palliative care and integrate palliative care. So it gives us enough time to build a rapport with the patient, to discuss difficult situations, to discuss goals of care, to document advanced medical directives, to explain to him how futile it is to put an advanced COPD and an advanced interstitial lung or any chronic advanced respiratory condition on a ventilator in the ICU and prolong the poor quality of life. So just to help us, there are clear-cut indicators which have been described in a couple of very interesting articles, which Pallium can share with you, where criteria for referral is also clearly mentioned. So if the patient satisfies any two of this criteria, which is recurrent hospital admissions or one admission in the ITU requiring ventilation, or the symptoms of extremely shortness of breath, even at walking 100 meters, patient on full-time oxygen, or patient on NIV, or patient with severe comorbidities, these are the patients you need to realize that the probability of him living for long is less. It is time to integrate and refer him to palliative care. So these are the two documents I was telling you is the one which we can share with you, which gives indicators for each and every chronic condition like renal, liver, dementia, motor neuron, COPD, respiratory diseases, etc. So we are happy to share this with you, and it will help you to actually your antenna to be alerted that this patient will require more hand holding, this patient requires and needs more support. Okay. So the reason also which is important is even in the West, where a lot of research has been done, palliative care is still focused on cancer patients. Unfortunately, less than 2% of patients get palliative care with the non-cancer diagnosis. And the other fall drawback is those patients with a non-cancer disease end up going to ICU more often, end up getting more aggressive treatment, more CPR, less distressing symptoms documented, and therefore they die a poor quality death. And this is, in fact, very, very sad, because the symptoms of a patient with lung cancer is as bad or probably less than what a patient of COPD suffers, the patient of interstitial lung disease suffers. The suffering, which none of us budget for, is equal or more in non-cancer group. And yet, unfortunately, this is not acknowledged and addressed. And we realize that even if we admit these patients in the ICU, patients with acute exacerbations of COPD, etc., the amount of times they get readmitted with their same symptom is 1 minute. Hi. So amount of times that patients get readmitted to hospital, it's almost 50% of them get readmitted to hospital. So we realize that it is futile to admit these patients, because even if we admit, what happens is typically pulmonologists focus on the admission. What happens to these patients once they go home? What is their quality of life? Our training also focuses a lot on quantity of life. So we must remember that even if we admit these patients, unfortunately, if you follow up these patients, 50% of them get readmitted to hospital. So what are we doing? We are actually prolonging their poor quality life and not contributing to the quality of life, which is so very important. And statistics also prove that in the end of 6 months, at least 50%, close to 40% of the patients are dead. And within 5 years, close to 75% patients are dead. So we must realize that we should focus on the quality of life of patients, add life to patients' years and not years to patients' life. Yes, we are not God to decide the expiry date of patients, but it is our onus to see to it that the patient's few last months or last years is not just a traumatic time of in and out of hospitals because there is ICU, because the patient can afford, because nobody has spoken to him about the trajectory. That doesn't mean the patient and the caregivers continue to suffer. We need to try and get those conversations in place and at least offer patients choices. In this country, very few patients get asked, what would they like to do? What is your opinion? And that is very important because all of you will agree it is the pillar of medical ethics. First pillar is autonomy. And we really need to ask patients what they would like to do because it is their body, their life, and therefore it has to be their decision. We just put our decision on them saying, in my experience, you should do 1, 2, 3, 4, 5. Tomorrow it's going to be our turn and we will like a doctor who respects our decision also. And it's the same for all human beings. So when you come to respiratory palliative care, and you therefore will talk about the most common symptom, which is breathlessness. And all of you know about all that I'm going to talk about, the evaluation of breathlessness. I'm not going to go into the detail, but the certain things which get missed are the pulmonary function test and the arterial blood gas and the CT scan, which is important to include to complete your evaluation for breathlessness. And we also need to explore what is that patient's particular stress because of the breathlessness. Again, we are not trained in this topic of asking the patients about how his breathlessness is affecting him. We stop at whether he's better, whether he's worse, whether he's able to walk this much, climb stairs, how the breathlessness has changed his life. Is he angry? Is he frustrated? There's a loss of role. He's socially isolated. He's constantly anxious. He's worried about death every time he's feeling breathless, correct? So these are the things that we really need to explore. And how do we explore that? Very often we ask the patient, is your breathlessness better? Are you more or less breathless? We need to change the way we ask these questions and ask them, what have you given up because of your breathlessness? Or what is it that you have stopped doing because you're scared you will get breathless? So it's important to ask your history in such a way that you elicit the right responses. So please remember that the way you ask the question also elicits the right response. It is the same like how you talk to your children or talk to your spouses. It is important, therefore, to master communication and continuously learn how to communicate effectively in order to get appropriate answers. Because why is it important? Because if you imagine a patient of chronic, if imagine a patient who's got chronic advanced respiratory diseases, he is stuck in this vicious model of breathing, thinking, and functioning. Because of the condition of his lungs, he's breathless. There's an anatomical distortion. There is a VQ mismatch. There is increased work of breathing. There's increased respiratory rate. And our patients spend about 30 to 32 breaths per minute breathing like this all the time. And at this point, when physically he is not active, the mind is overactive. So anything that triggers his breathlessness, he's going to get more anxious, more scared, or irritated, angry, and thinking of death, and maybe even end up going into a panic situation. And because of these two situations, the patient just refuses to move because he says, oh no, last time I went to the toilet, it took me half an hour to recover. So it's best I don't go to the toilet. So then it becomes a bedside commode. Then it becomes a diaper, less and less activity. And you know, in the muscles, if you do not use it, you lose it. So the patient continues to become more and more deconditioned. So here is a patient who is breathless and he therefore is anxious and therefore he stops moving and he becomes more deconditioned and he feeds into more breathlessness. And this is where the beauty of the multidisciplinary team of palliative care helps, because a pulmonologist and the palliative care physician work on the breathing, give him medications, give him non-pharmacological, pharmacological interventions. The counselor, the psychologist helps with the thinking, and the physiotherapist makes him functional so that he can do activities of daily living with as less effort and dependence. And so multiple prong attack. So you have a social worker, you have a counselor, physiotherapist, the pulmonologist, and the palliative care physician and nurses. So the pulmonologist can focus exactly on what is his forte, on looking after the chest, on improving his chest. And all these other things can be looked after by the palliative care team, saving time for the specialist, win-win for the patient and caregivers, and obviously a great way to look after the patient and improve the care experience. Because our patients with chronic advanced lung disease are in a situation described as chronic breathlessness syndrome. And this was a term coined in 2017 by two people who are done a lot of research in patients with advanced lung diseases and congestive cardiac failure. So chronic breathlessness syndrome is a condition where patient continues to be breathless despite maximum medical treatment of his condition. And when this breathlessness affects his social, psychological, emotional health, that is what we call as chronic breathlessness. It's not just a physical symptom, it affects the total pain and enhances and worsens the quality of life of the patient. So what we are taught as doctors very often is to focus on the pharmacological treatment. We are ready to write a prescription and finish the chapter. But a lot of other things contribute to helping patients and caregivers to look after patients who are chronically breathless. You cannot afford to forget the non-pharmacological interventions that you could do. This helps the caregivers. For example, positioning of the patient, whether it's head low, head high, right lateral, left lateral, next to a window, well-ventilated room, not surrounded by people, loose clothes. Physiotherapists can teach some relaxation mudras or relaxation techniques. Some music and pet therapy to distract the patient. And one of the very effective things that has been proven and documented in literature by doctors is a handheld battery-operated fan. If you blow it to the patient's face, there is a sensation of reduced breathlessness. And this has been documented by serial MRIs done at that time and shows how the respiratory center also is sending less signals to the lung. So please remember, simple techniques can help the caregivers also feel that they are contributing to the care of the patient. Also, if a patient wants to do certain activities which he enjoys, help them plan, prioritize those activities so that they can get the joy of doing it. For example, if a housewife like to make some dish, See to it that somebody is helping them with all the things required. So somebody's put everything there so that the person can come and just do it and have the joy and satisfaction of having been able to cook for the family. So these are small pleasures, but it really helps a lot. And coming to the pharmacological, again, you are a bunch of doctors trained over so many years. I don't need to tell you about the bronchodilators, steroid, nebulization, etc. Word of caution about oxygen. Oxygen is also a drug. Oxygen should not be abused unnecessarily. All patients who are breathless should not be given oxygen first without checking the saturation. Please try the non-pharmacological interventions first. Check saturation. If it is below 88, oxygen will help. If it's above 88, then oxygen is not going to help. So please remember that. Then rational use of antibiotics. During the COVID, we saw how we kept saying COVID is a virus, COVID is a virus, and yet so many people got antibiotics. It is only going to worsen the antibiotic resistance in our country, and we should use it judiciously. And obviously, we need to talk about morphine, which is a very, very important medication for chronic breathlessness. Patients should be evaluated in great detail and explained about the use of morphine, the care of morphine, and very small doses are extremely effective in reducing the sensation of breathlessness. Morphine works centrally. It reduces the work of breathing. It improves the respiratory rate and the tidal volume. And therefore, the patient takes fewer, deeper breaths, and it improves the gas exchange, and patients feel less breathless. And nothing happens to the lung. There is no bronchodilation. There is no anatomical change. It's only that the patient feels less breathless. And in the 5 to 6 years, I've never seen a patient who goes into respiratory depression because we use very, very small doses to start with, and we don't even go very high. Also, carbon dioxide retention doesn't get worsened because if a patient has type 2 respiratory failure or has the tendency to retain carbon dioxide, we almost always use BiPAP along with that. Any questions or comments on morphine or anything at all? Okay, so moving on, it's also important, therefore, to focus on what is called as terminal breathlessness. And what is terminal breathlessness? It's not something that is experienced only by patients who have advanced respiratory diseases. Patients with cancer, patients with CCF, patients with CKD, all experience breathlessness at the end of life. And this is also very important time. Should it be given oral or IV? Oral, I'm coming to that. IV has specific indications, which also I will come to, like I'm talking about terminal breathlessness. So terminal breathlessness is very, very distressing for the relatives and sometimes for patients also if they're alert. And it is our responsibility to see to it that the experience of the patient during transition from life to death be as comfortable as possible. You also know that the quality of death index in India is very poor. We rank amongst 59th amongst in the world. So it's important after a detailed evaluation, discussion, documentation, and reassurance and involvement of all the stakeholders that we can and must treat terminal breathlessness. So when we talk about terminal breathlessness, we should realize that this is something that's going to make the patient unresponsive. And therefore, we need to be very sure that the relatives are comfortable over it. We give it as an infusion, in a syringe driver, along with 10 milligrams of midazolam and morphine over 24 hours so that the patient can transition in peace. So intent is comfort. Intent is not to end life. So there is a fine line, but terminal breathlessness is actually aggressive control of distressing symptom of breathlessness. When patients and relatives rather that the patient is unaware of his distressing symptoms and not awake and miserable with his breathlessness. Somebody has asked about NIV. I will talk about it. It is a completely difficult topic, but I will talk at the end of it. The other distressing symptoms also in the respiratory system could be cough, pleural effusion, hemoptysis, and hiccups, each of which should be acknowledged and treated, because everything is difficult when it's recurrent. And when it comes to cough, again, morphine does a good job, codeine does a good job, but we need to realize that presence of cough is not just respiratory. It could be cardiac, it could be upper respiratory, it could be ENT, it could be gastric. So a detailed history is very important before you start addressing. And of course, you have to do all the evaluation that I mentioned before. Pleural effusion, again seen in malignant settings. The treatment of that depends upon the prognosis of the patient. If the patient has a good prognosis, more than 4 weeks, you can do a pigtailing to drain the fluid. If the patient has poor prognosis with a poor general condition, then it makes sense to put the patient on a one-time aspiration and settle his symptoms with with morphine. Similarly, hemoptysis and hiccups, if you should be able to tell a patient to expect blood, but with hemoptysis, what happens is you cannot do home care for control of hemoptysis. Patients should be given contact numbers where emergency treatments like bronchial artery embolization, laser, cryo, etc. are done, and patients should contact these people way before the emergency takes place. So if the emergency doesn't take place, it's fine. But when it is, the patient needs to know where he needs to go. Another important point where palliative care makes a huge difference is the pandemic. We all suffered, patients suffered, doctors suffered, caregivers suffered. If we were all trained in palliative care before the pandemic, we would have handled it much better. We would have known which patients to admit in the ICU, which patient to keep at home, which patient to ventilate, support each other, prepare the relatives for the difficult grief and bereavement. So palliative care has a huge role and in a humanitarian crisis, and the pandemic was one example of that. Because with COVID patients, we really should have applied medical ethics, triaged the patient better, selected which patients go to ICU, those which not in the ICU, we should have given them utmost comfort care and communication with the caregivers and the relatives who were not even near the patient, and handhold them during the grief and bereavement. The other aspect of respiratory is in the casualty and the emergency. The recent Supreme Court judgment allows patients to have a living will and advance medical directive. There is medical, legal, and ethical intentions of withholding and withdrawing care. It is allowed if it is in the best interest of the patient, and we must all train ourselves as to how to communicate all these with patients. And if a patient has had a stormy ICU for a chronic illness, we should be able to talk to those patients about what his thoughts are on readmission and his goals of care, right? So with this, I can stop this presentation and answer the few questions that have come. One is about NIV. Now, NIV is a completely different topic, completely separate topic. It is non-invasive ventilation. We have the continuous positive airway pressure and the bilevel positive airway pressure. Usually, the continuous positive airway pressure is used for patients with obstructive sleep apnea, where it provides a pneumatic splint to keep the upper airways open, because in obstructive sleep apnea and central sleep apnea, the central airways collapse, and therefore the patient actually in his sleep gets up like somebody is strangulating him. The other form of BiPAP is the bilevel positive airway pressure, which is typically used in patients with congestive cardiac failure, because it helps to squeeze the fluid out of the lungs into the system, as well as those patients with type 2 respiratory failure, where there is a high level of carbon dioxide in the blood. So we need to talk to patients about these use of these non-invasive ventilation, because they are fitted around the patient as a tight mask. It can be very claustrophobic. Patients can get very uncomfortable. It can be a barrier for communication. And sometimes patients are extremely uncomfortable. So it defeats the purpose and ethos of palliative care. So careful selection of patient, trial of NIV. Some patients really like the NIV, especially during sleep, etc. And it should be used judiciously, but it is best under the purview of pulmonologists and cardiologists who use it with acute LVN. Okay. Any questions? There are some here. 1 minute. how to make a living will. Now that is again another topic on its own. But yes, if you go to the Indian Association of Palliative Care website, there is a living will format and a pro forma. Supreme Court in this January has made the living will logistics of making the living will much easier, but the lawyers are still unaware of it. What I encourage my patients is have a conversation with your loved ones, include all the ones in your family, talk to your GP, write this format and stick it on the fridge. So in an emergency, everybody knows what needs to be done with this patient, whether he should be resuscitated, whether ambulance should be called, whether patient should go to hospital, ICU, intubated, whatever. Sometimes patients say, I'd rather be in hospital, but I don't want to go to ICU. We should encourage maximum ward care because the right of every patient to be comfortable. And it is not necessary that ICU, ventilation, etc. only makes you comfortable. So we need to explain that to our patients. How much dose of morphine in managing terminal breathlessness, which I mentioned before, 10 milligram vial or 15 milligram vials are available. One vial along with 10 milligrams of midazolam plus or minus haloperidol if the patient is agitated. That solution is given over 24 hours, which is mixed in 100 ml saline or 100 ml water for injection, but that is given over 24 hours. So, but again, we have to titrate. If the patient is, the intent I said is comfort. So always the mantra in palliative care is start low, go slow. Start with the minimum dose that is required to make the patient comfortable. Once the patient is comfortable, then you review frequently if you have to increase the dose. Never start with a whopping dose because that will actually not be the intent of your care for the patient. Any thoughts, questions, or comments?
Thank you, madam. They can either, you can even unmute and ask, or choice is yours. Like either way is fine. If you all want to even unmute and ask any specific queries.
Madam, role of euthanasia in terminal breathlessness.
So as a country and as a human being, I don't approve of euthanasia simply because in a country where there is no robust palliative care, talking of euthanasia is actually futile. And who are you and me to decide when a patient should stop living? It has to be somebody else's decision. One. Two, why do we talk of euthanasia and chronic illnesses? Because the patient is suffering. If you address the suffering, do you think the patient wants to die? Everybody holds on to dear life as much as possible. So if the patient is in pain, you have ignored the pain, patient wants to commit suicide or wants to die. If you've ignored the breathlessness, if you've ignored his depression, if you have ignored his financial trouble, oh God, they're spending so much on me, now they will come on the road. So if you address, so I'm not saying you can change everything, but the fact is you have to address it, acknowledge, yes, this must be very difficult for you. What can I do to support you? Do you think I can get some money? Do you think I can send you to some trust? Do you think I can give you some letter? Do you think I can educate your children or get your daughter married? So it's not all possible. I appreciate that. But we have so many NGOs. We have so much crowdfunding in this country. What we don't have is talk to our patients. What is bothering you? What can I do to help you? And believe me, today, even if you ask anybody, what is bothering you? How can I help you? Are you coping? That itself decreases 50% of the person's stress. I don't know, maybe in my previous sessions, I have shared this. When I was training in England and doing my MRCP, my mother visited me, my parents came to me, and within 1 week of them coming, my mother found a lump in her neck. And to me, I thought of the worst. I took her to the surgeon there because I had to do a biopsy and see what it was. And my mother then described that the 6-foot surgeon sat on the floor of the consulting room so that he comes to the level of my mother, put both his hands on her shoulder and said, "Yes, young lady, what have you got for me from India?" And Amma said at that point, 50% of her trouble was gone, because here was this man who was so concerned, looked into the eyes, spoke to me like he was really cared about my problem. The point what I'm trying to make is we need to be able to touch that chord for our patient who is suffering chronically. If we address his suffering, and if we be very honest by saying that I can't make your disease disappear, but I will help you as much as possible, nobody will say, okay, but still I want to die. So I think in a country where there is no palliative care reached to every human being, it's a birthright for every patient, we should not be talking of euthanasia. There is so much to do to comfort a patient, and it is not just by doctors. And that's the beauty of palliative care, that there are nurses, social workers, volunteers, psychologists. We need to use these paramedical people. And I know by experience that my parents used to be happy seeing a physiotherapist. Young physiotherapists, they used to talk of the weather, the train, the politics, some different topics, some entertainment, but we have to try. And government hospitals also have these paramedical, so for our patients who are not affording. NGOs like Pallium do absolutely free treatment. We need to utilize these services. And again, in the IAPC website, there are full addresses of palliative care centers across the country. We need to at least try to help our patients. And it takes only 5 or 10 minutes if you have learned effective communication. Are you coping okay? Do you need help? Is there something I need to ask you about? Or do you want to share something that is, it's okay if it's not even medical. So you don't have to sit and handhold the patient, but if you identify the problem, express and acknowledge that, yes, this must be so difficult. Like, for example, today I met a patient, 68, very busy journalist, high top job, had to quit because of his breathlessness, has fibrosing interstitial lung disease. His daughter has just delivered a grandchild who's 1 month old. He's come from Chennai here to spend time and he's gotten so sick. And just imagine the stress in the household, irrespective of the socioeconomic. There's a newborn baby, the mother is postpartum, his daughter, wife is torn between being a wife and a mother and a grandmother. Even with all the help, there's so much stress. We just need to acknowledge that and try and give them directions. Okay, get extra help for the patient, try and do this, get a physio, get a counselor. So those are the small tips that we can do to improve their life. I don't think we should be talking of euthanasia. It is not your or my decision to end a patient's life. I think it's very wrong, is my opinion. It's open to the floor. We have other 50 doctors who can give me their opinion.
Just one thing, total care. Like as madam was telling, many of us are not aware. And then maybe sometimes, we are focused on our aspect. Okay, I cannot get social. So from that point of view, when you start working and have palliative care aspect, you can just link. Why I'm telling this is there are many groups and NGOs available willing to help, but they don't know whom to help. Okay, so in those, for example, teaching or educational assistance, n number of people are willing to give, but they don't know to whom to give. They want to make sure. So just forming a link for all this, organizations do help. So just combining, you have someone who needs help, there is someone who is willing to help, just linking them. So these type of things, you have to go out of your box. See, we are all comfortable with medicine. See, that's how we are all made. But slowly we have to open up our eyes and see. As madam said, I've also been an anesthetist all my life, but for the last 5 years, from 2017, I've been into palliative care. And you have to come a little bit out of your box and get help, and you can do. And finally, one more thing is, even if someone comes up and asks you that question, our duty is to tell everything to them. Okay, your disease per se, your prognosis, your options on whatever is available. I'll tell you everything. Then your decision is final. Autonomy has a final role. Okay. After seeing all this comes up means that is different. Okay. So we can't say straight away without analyzing and seeing all this. Even for someone with very life-threatening illness, we will do 200% to see if something correctable can be corrected. Only when it's not there, we go to care. So that part has to be done. So total care. So physical, emotional, spiritual, psychological, everything has to be looked into. That is one thing. And
Other
then
thing is, one more point I would like to add, for a patient, like Radha mentioned, to make a decision, patient needs to be fully informed. Whose responsibility is give the patient the information? It is our responsibility. We can't say, you know, it is ILD and, you know, it is progressive, it is incurable. The patient has 200 more questions. You have to give the patient an information as to anatomy of ILD, what happens in ILD, why you breathless, how it will progress, how it is futile. If I put you on ventilator, the lung is only not there, in a manner that he understands so that he can make his decisions. You can't break the news and say, okay, now decide. You have to, then he will do Google search. Then we doctors only say, these patients come with Google search. We don't give the information, they will go to Google search. It is natural. You and me also do that. So we have to spend time. And it's not that out of your 10 or 20 patients in the OPD, all of them will be in the same level, right? Identify those at high risk of this kind of discussion and decision making. Keep them aside, give them the last appointment so that you can spend time with them. Because we are all in, unfortunately, again in India, 80% is private. They're paying money for this. So it's like, it is like a customer service, right? You will hate the shoe you have ordered online. If it is not the way it is, you return it. Now, what do these people do? They will shop around. So we need to see to it that we are able to satisfy. And it's okay to be honest, saying, I don't know. I don't know how it's going to be in the next 6 months. It is not wrong that I'm also human. Things change every day. I will consult another doctor. Like I have a patient again on MND on 100 milligrams of morphine with no relief of pain. I had to admit to the relatives, I have to go back to the pain specialist, see if I can do some intervention, see if the patient is a morphine non-responder. I will come back to you. But I really don't know. I've never seen such a thing in my life. It's okay to not know. Even we are human. But communication, honesty, and transparency is very important. I think that is one of the reasons why faith and trust in doctors is at all-time low. And it is up to you and me to make that go up, because actually the only place to go up when you hit rock bottom is high. So hopefully you, with so many palliative care physicians trained, we make that difference to get back compassion and empathy into a field which is closest to human suffering and death and dying, isn't it? Doctors are the ones who deal with people all the time who are suffering. We should be compassionate and empathetic to their needs. Any more questions or thoughts, or what is the role of?
Something is in the chat box.
What is the role of oxygen apart from oxygen LTOT apart from morphine? I didn't get the connection. LTOT, which is long-term oxygen therapy, is something we offer to patients who have chronic advanced respiratory, such as gold criteria 4 or 5, or interstitial lung disease, which is progressive. 1. 2, if their oxygen saturation remains less than, pulse oximeter may less than 88, and there's a desaturation on the 6-minute walk test, or they have pulmonary artery hypertension, which is cor pulmonar. So those are the patients we offer low dose, low flow oxygen so that they maintain their saturation between 88 and 92. Morphine is a drug which is given for chronic breathlessness, where patients continue to be breathless despite everything that you have tried. So there are two different indications, and the role of oxygen is very different from morphine. And please remember also that you should use both morphine and oxygen judiciously. It is not a panacea for all patients who are breathless, because anxiety and panic also can cause breathlessness. Today, if you're in pain, that also can worsen your breathlessness. So please remember, it is not some blanket thing for everybody. If
Maybe we
no
could
other
go ahead
questions,
with-
I think when Dr.
Go
John
ahead.
is presenting today.
We can go ahead with the case. That's all. Yes, Sri Priya, can we go ahead with the case presentation?
Sure, ma'am. Dr. John?
Yes, ma'am. Yes, ma'am.
Yes, you can start. Anu, can we have the slides moving, please?
Yes, ma'am.
Vijay Umar, 65 years old, male. He presented with dyspnea, which is progressive over 1 month, productive cough for the duration of 1 month. And he also complains of right-sided lower chest pain for 1 month. He also has the complaints tiredness, loss of appetite, and loss of weight. History of illness. He presented with exertional dyspnea for 1 month, which was insidious. Its exertion in level ground, and it gradually progressed to dyspnea over rest in 25 days. There is no orthopnea, no paroxysmal nocturnal dyspnea, no aggravating or relieving factors, no postural or diurnal variation. He also complains of productive cough with mucoid waterless sputum, which is non-purulent, and is around a quarter a cup in a day in quantity. There is no hemoptysis. He complains of right-sided lower chest pain, and the pain was a dull aching type, continuous type, and it hindered his sleep. There is generalized weakness, loss of appetite, and there's a loss of weight from 60 to 55 kilogram in last 6 months. Loss of 5 kilogram. On examination, there is no pallor, no icterus, no cyanosis, no edema. There's a grade 2 clubbing, and there's a left-sided supraclavicular lymph node which is hard, mobile, and non-tender. JVP is not elevated. Thyroid is normal. Pulse rate is 102 per minute, regular. BP is normal. So respiratory rate of 24 per minute. As SpO2, 93% on nasal pumps with 2 liter oxygen. Accessory muscles are involved. And on examination of chest is normal in shape, bilaterally symmetrical. Trachea is central. The movements are decreased in right side. Chest movements are decreased in right lower chest. Chest expansion is 0.5 centimeter in right and 1.5 centimeter in left. Anteroposterior to transverse ratio is 0.61. Vocal function is reduced in infrascapular, infraaxillary, and some mammary area. Percussion, there's a stony dullness in right infrascapular, infraaxillary, and inframammary area. The sound and vocal resonance is reduced in right infrascapular, infraaxillary, and inframammary area. Next investigations. Aspiration of pleural fluid. Examination shows hemorrhagic fluid. Cell count of 360 per millimeter cube. Predominantly lymphocytes. Protein content is 3.5. And the serum protein is 6.3. So the protein pleural fluid is to serum protein ratio is more than 0.5. So glucose content is 92. LDH more than 180, it is more than 150. And on microscopy, SO4 percent in hyperfluid, and AFP acid for specialist test is negative, and the culture is sterile after 48 hours of incubation. On CBNAT is negative. On FNAC, left supraclavicular lymph node is suggestive of metastasis from poorly differentiated carcinoma. And on fiber optic bronchoscopy, right lower lobe bronchus have mucosal irregularity with neovascularization. wash and bronchial blush cytology suggestive of poorly differentiated carcinoma is possibly adenocarcinoma. Bronchial biopsy confirmed the diagnosis of adenocarcinoma and the TTF1 was positive. Psychosocial aspects. He has 3 siblings, 2 daughters and a son. And he now lives with wife and son. The son works as a driver. He studied till 8th standard and was working as a carpenter till 1 month back. He was a smoker for 45 years, around 15 BD per day, and drinks 2 peg brandy per week and has a history of exposure to sawdust. His wife is a manual laborer. He lives in a well-ventilated packer house. Main concern is removal of tumor, pain relief for better sleep, the reduced treatment cost by involving NGOs, and the improving his quality of life and life expectancy. In summary, patient is 65-year-old male, carpenter by occupation, who is a smoker, now presented with complaints of exertional breathlessness, which is gradually progressive and now a grade 4 MMRC over the past 5 days. Complaining of right lower chest pain, dull aching, continuous type since past 1 month, and mucoid cough with mucoid expectoration amounting to a quarter of a cup per day for past 1 month. She also complained of generalized tiredness, loss of appetite, and significant loss of weight. On examination, diagnosis felt in right infrascapular fracture in the mammary area. Investigations revealed an adenocarcinoma right lower lobe with a left supraclavicular lymph node and metastasis to thoracic vertebra. Discussion points: how much improvement can Alichi care bring in his case? What are the ways in which we can support the family? Just here's a metastasis to contralateral lymph node and thoracic vertebrae, grade 4, stage 4 adenocarcinoma. He needs to be.
So the way to answer that is, you have said it is metastasized adenocarcinoma. What do you know about the survival of patients with metastatic adenocarcinoma? And how else will you know how palliative care, what are the questions you can ask patients to see if you think palliative care can improve? What is your definition of improvement? As doctors, unfortunately, very often the improvement is survival. The longer you live, the better it is. So we focus on quantity, like how we focus culturally in the country. But what is actually good? Is it enough if the patient is alive, or it's enough if the patient lives well? So what are the questions you can ask the patient to see if palliative care can make a difference? What will you ask the patient? Yes, Dr. John, Babu, you're very quiet. Anybody can answer. It's not a big deal. We can stop sharing and see everybody's faces, and you tell me, what are the questions you can think of asking the patient? See, in the beginning itself, I told you that palliative care is a need-based science, or rather an art, not even science. It is an art. It's a need-based topic. So if you can have a stage 4 cancer patient who is coping very well, and you can have a stage 1 patient who is not even able to spend 1 day without crying, or you can have a person who has very complicated social structure, like husband is rude, or children are jobless, or children, there is a special needs child. There's so much going on in the life. So the need, because palliative care is a need based, not prognosis or diagnosis based. So what are the questions you will ask your patients if you have made the diagnosis of stage, whatever, metastatic adeno-CA of the lung? Irrespective of how the TNM staging and the 5-year survival and all of that is, what questions will you ask your patients? Think about it. Not rocket science. And this is where empathy comes. So if you think you are going with a loved one and the loved one has been diagnosed a particular illness, what would you want the doctor to ask you? Yes, Harsha?
Ma'am, I would ask the patient how is he feeling right now? How is his breathlessness?
Yes.
Is he having breathlessness at rest even while sleeping, or is he
You'll
comfortable?
inquire about, you'll evaluate breathlessness.
Yeah, and then
Very good.
his sleep pattern means how is his sleeping pattern? Is the
Yes.
disease progressed so much that he is unable to have a quiet sleep at night? And
Do anxious people sleep at night without
No.
having cancer?
No.
So it's not just physical. When you see people who are not sleeping at night or you're sleeping at odd times, it's not always physical. So what are the questions you will ask? Very crisp questions. This is all something that all doctors will ask. Khasi,
Whatever
bukhar, breathlessness. What will you ask?
how the condition has deteriorated the day-to-day quality of life, whether the patient
Okay.
is able to conduct the routine activities like taking care of their body,
So
oral
you
care.
can, what are the easiest way of asking? What are you stopped doing because of your symptoms?
Right.
Or what do you avoid because of your breathlessness? How has breathlessness changed your life? And that is when the questions will come. I have stopped doing this. Oh, I need somebody to go to the toilet. Oh, and then all those things will come. Then you know this person needs help. So call the physio, call the occupational. Then you can directly ask, are you in low mood? Are you feeling low? Do you feel like crying often? So are you feeling hungry? Or are you able to sleep? So those are the questions you can ask directly. There are very patients who say, yes, I don't feel good. So what is the meaning of feeling good? Even if you have, suppose a doctor is given that there could be side effects of the chemo. There could be side effects of the treatment. So everything we give, sometimes the treatment is worse than the illness. So we need to appreciate that and address it. And for that patient's sake, need to make those few calls to the occupational therapist, the physiotherapist, the counselor, to see how we can help. So are you coping? Somebody has written in the chat is a good way. How do you translate coping in the regional language is my next question to you. I struggle. I don't know how to ask a patient in Marathi, in Hindi, even in Tamil. How are you coping? Can anybody translate it for me? It's very difficult. Please try. Some words in English, now I find it very difficult. Like, for example, a patient is at end of life, to tell a relative that things are looking uncertain. Uncertain is a word I cannot describe in Hindi, English, Tamil. I don't know what to say. Uncertain explains everything. I really don't know what's happening. It'll be good, it'll be bad. I really don't know. I'm concerned about what's going to happen. So coping, uncertain are difficult words. So coping is a correct word to ask a patient, are you coping, with this thing? But I don't know, can anybody who is literary translate into regional languages in India? You can send this as a chat, because this is another thing I think we should include in communication is vocabulary, because certain words you get stuck and then the English word comes and it doesn't help certain patients, Coping is very difficult to translate. So you can ask directly.
No, just from this thing, open-ended, what they would have all had in communication, have an open-ended question rather than a closed-ended question.
That's true.
Closed-ended question is not helpful at all. You ask only what you want. So let it be an open question. That is one thing I just thought of telling, so that you give room and chance for the patient to explain.
Yeah.
Rather than you going on. So that is one thing.
Premlata has commented, what are your concerns or worry? Yeah, very good. concerns or worries bothering you now, either health or general? Yes. But please, your homework is coping ka and uncertain ka. All languages mein
Exactly. It's really a tricky one, madam, because
I struggle.
for telling in English, oh, how are you coping? Easy, one word. But when you say, we have to ask, like, generally is your normal day-to-day activities, looking after yourself. That is something. Are you able to, like, for example, go to the toilet and things? That's why it cannot be a one word. Because English,
yeah, correct. English, Shri Priya said, "Epdi samal," but that is manage, na? Is it cope? I don't know. Tell me more about your. Yes, very good. That's a nice way of saying. Tell me more about it. So honestly, while you're typing, you need to be honest to yourself. Do you use these phrases with your patients? We're not trained to use. You should make a difference. And there's another medical question here. What is the right way to treat saturation drop with wheeze? So again, it is based on the diagnosis. If there is wheeze and there's a diagnosis of asthma, then you should be giving nebulizer. You should be giving, if there is a drop in oxygen, you have to give oxygen and steroid. So it all depends on the etiology, but it's very difficult. Everything that wheezes is also not asthma.
no, cardiac wheeze, respiratory
Yeah.
wheeze, we can
That's
have
what I'm saying.
everything.
You
No?
can give, you
So,
probably have to give Lasix or steroids and nebulizer
exactly.
and oxygen.
See, cardiac and respiratory symptoms can be so similar.
Yeah.
So you need to, that's why where your history of the patient will come handy for you. Most, if the patient, chronic cardio, if it's a congestive cardiac failure patient, so you have to have all those in mind. That's why I generally feel like you have to be all round. That is when it will help. Just one thing alone. And we've all been taught to see patient as a whole, just not the symptom alone. So the same thing only is coming back now. See, we all read this in Hutchison's and what we did when we started. In between, we forgot. So just it's just a repetition for us to tap and say, oh, you just remember that once again. So see the patient as a whole, not just as one thing. And especially these type of things, no, only when you face the patient, that's where experience and practice comes in. So when someone comes in us at that point of time, so if you prepare yourself ahead for it, you feel better and comfortable to face it.
Yeah.
And madam's
yeah.
vocabulary homework may come handy for all of you, because day to day.
Veena Pinto, I would like you to say that to me, though I can speak little Kannada. Hege, then I don't know how to say it.
Ma'am, ಹೇಗೆ ನಿಭಾಯಿಸುತ್ತಿದ್ದೀರಿ?
Mean, what does that mean? Coping, is it?
Coping. ನಿಭಾಯಿಸುವುದು, like Hindi, कैसे निभा रहे हैं? Something like that.
Good. I'm glad there is something.
And Hindi also, someone has typed something.
Is
आप
it?
कैसे
सह रहे हो.
आप कैसे सह रहे हो?
सह रहे हो is to सहना is
Bearing.
correct.
Bear.
Yeah, but maybe tolerate and yeah. But
That is
does it
endurance.
cover? But does it cover
Endurance
the
is an-
emotional abstract thing? It is more physical. To bear,
Sahana
to
is
tolerate.
to tolerate, isn't it, madam? Tolerate and endure.
Yeah. So
So
tolerate,
maybe that's-
and it could be mental also. Tolerate suffering. Yeah,
See,
it
these
could
are all synonyms, madam. You can have so many synonyms.
Yeah.
That is the thing. But easy, as I said, no, normally one word may not match with one word. See, even with all the like things what have been typed. So what generally we say, what is said in one word cannot be said in one word. You may need more words. That's what linguistic skills next.
Done. So these two homework you all have, but questioning, see, also sometimes when you make the patient talk, now that itself is cathartic for him. Our agenda is to get out of our to-do list. We only keep talking. We never listen. Because it is finally his story.
Listen is a mantra for palliative care.
His story, right? We don't give him a chance. A lot of things, na, even when you and me have had a rough day, if somebody listens to us, we feel good. When you have a spouse who's also busy looking at the phone, it's irritable, saying, you haven't even asked me how my day was. I had such a bad day. Or whatever. Or if you manage to do something very nice, or you've not even asked me what all happened today. So listening is such an important thing. That's same with our patients. How are patients any different? They are also human beings. Yeah. And then the second question was, how can we support the families? Our family, of course, we have volunteers, social workers, asking if there's some way we can help to educate the children. So many things can be done. All this can be done only if you ask. Otherwise, if you don't ask these questions, you'll never know what is underlying the patient's stoic face. Because in India especially, patients get very intimidated asking stupid questions to doctors. Doctors also respond like that, saying, what is this? The facial expression, the body language is what a silly question to ask. But there are so many pressing questions. Off late, I have realized even more. When I have young patients of interstitial lung disease, earlier I used to never know how to ask them about their personal life, about their sexual intimacies, about what they do, 30, 40, 50-year-olds. How to ask them this question? They're so chronically breathless. That's the only thing that's in their head. But imagine their spouses. They're also leading a life of caregiving, married to this person who's chronically breathless. But I have come out of a way and made it more comfortable and made it a point to ask these patients, is there something you would like to discuss about your personal intimate relationship? And leave it at that. If they don't want to talk about it, it's their problem. But at least I have asked, because I know it could be a big deal with patients across the socioeconomic status. So we need to get comfortable asking these questions. We need to get comfortable asking about death and dying. We need to get comfortable because we ourselves squirm at that thought, how to ask and what to do. When we look uncomfortable, we obviously blurt out the wrong terms. Any questions? Any thoughts?
In this case, no, the wife has, like, at least we have to talk to the wife and see whether she understands what it is. And because his stage 4, because many times wife may not even understand. So have we conveyed what is his condition, and next make sure whether she is understanding that. So that is also equally important, because how I'm telling this is, couple of times when I have seen patients, I remember a 50 plus gentleman who had stage 4, and he was really in a very end of life situation. Only wife used to come. The children, 2 daughters, never came at all. And so one day it just struck me asking, and then the husband tells me, no, she does not know anything. You better tell her. Then I said, what is this? You are so unwell. So we had to talk with the wife. So those type of situations, it is better that if she knows everything, well and good, but we should not leave someone in a situation that they were not even aware of it. So unfortunately, that patient whom I'm telling, in a week or 10 days, the patient died. So at least I felt a little bit relieved that something only, it was the good stars of that patient and his wife, which brought that question in my mouth. Because the daughters didn't come at all. In 3rd day, he ended up going into ICU, and then by day 10, he died. A 51-year-old who was actively working. So those type of things, no, if they know, well and good. But if we don't miss anything, we will also feel better. So just make sure that here in this, no, that's another thing which you explain, and then look at if she is okay, aware, and then ask her. We have to give some, as we say, no, patient and carer equally important. Because how much importance, that's what palliative care definition itself is transforming now. Both are to be taken care of. So that has to be practiced as you keep doing. So that is something came to my mind. So you could just make sure that also is added.
Thank you, Radha. Anything else? Anybody wants to say, suggest, any clarifications? So my last question to all of you, is after today, what are the changes in your thinking, in your heart, and in your hand? So what have you understood? What has made a difference? And from tomorrow, what is it that you will do differently? That is the impact of my talk. So suppose
it'll be nice if someone tells something, madam. That's what.
Yes.
Even single words or whatever
Or
that
even
the
put it
3
on
questions
chat.
are. That's the aim and objective of the whole course. It is.
Totally.
So it could be a one word something. It will be nice to get something. So
and it need not be after my lecture. Whatever you've learned till now. What is
exactly? It's an
heart
open
and hand
thing.
situation? What have you
What
learned?
change has this brought?
How has your thought changed? How has it affected you as a person? And what is it that you will start doing differently from tomorrow when the next patient walks in? Listen to the patient.
Very good.
Thanks, Puneet.
Would like to ask open-ended questions to the patients, and at least after starting attending this session, I have been more compassionate to my patients. Like, I'm an anesthesiologist, so before whenever I induce the patient, before that I try to build a rapport with the patient. I try to talk in general about आप क्या कर रहे हो, आपको क्या तकलीफ हो रही है, आपके घर में कौन कौन है, and then when I get the patient in my comfort zone, I try to anesthetize the patient. So even after the surgery, when I ask the patient, "Aap utho and how are you?" So they are happier than they were the previous patients whom I used to do. So this has helped me in better communication skills with my patient.
And that is a work in progress. Even today, there are times when one gets stuck. So keep at it. But it's a great start. Thank you.
Yeah, thank you.
Thank you for sharing. Some other person has entered a chat to start palliative care along with regular treatment for the smooth transition. So important, because really tomorrow all of us are going to be patients. So that's great, Sharath. It's so important not to feel abandoned and to feel cared for by your physician. Anybody else? I don't want to overshoot the time also and keep you all from your evening chai. So if there's somebody else, I'm spending more time with my patient and family. Yes, but please see to that you look after yourself also, because if you're a very busy doctor, don't spend so much time that your family is saying no time with us. So work-life balance. I joke and say it should be life-work balance, because work should come after life. Otherwise, it can get too over-consuming. So look after yourself, get your me time, exercise, have fun also. Simply because we do deal with a lot of people who are suffering, and sometimes you carry that back home. So it's very, very important to look after yourself. I always used to escape when patients start talking about their non-medical problems. Very nice that you're honest about it, because we all hate that Pandora's box. Because once you feel, oh God, no, I don't have the bandwidth to listen to them. So therefore, it's a very honest comment, and hats off to you, Veena. It's very important that you should ask those questions at relevant time to relevant patients, and then say, I agree that it's too much problem, but I will need so much people to help you, and I will direct you to those people. Then it's not your purview, but obviously you coordinate the care. Great.
Right balance, as nothing should overshoot and ruin your see, we need to give patient care, finding out that no beating around the bush, go to what is to be tackled and then deal with it. See, in these situations also you need not be abrupt, but we can tell them, see, whatever can be solved, we will try to solve, but what maybe this may need other additional support and things that we will guide you. So something like that, so that you make sure you have your time frame also. You don't overshoot and then end up getting burnt out. That also is equally important.
So if there is nothing,
Yes,
Shreya, over to you. Thank you,
Hmm.
Radha, for helping me facilitate this. And thanks to all of you for coming on a Monday evening. Have a good week ahead and stay safe. Shahina has written, it's nice to get advice from you, I think. Thank you. Thank you, everyone. Thank you. I can see Veena is multitasking. There's a little one now. Thank you for joining despite all that. Thank you. Shri Priya, do you want to share the link of feedback or it doesn't happen anymore?
It is happening, ma'am, definitely.
Happening.
Are sharing the link for
Okay.
feedbacks, but then
Hmm.
only some are actively participating in that. But I believe since you have mentioned it, all the participants will be kind enough to provide the feedback of this.
I think it really helps the facilitators to do better when you send the feedback. So please do send the feedback and it really encourages us or improves us, both of which is important. And
Sure.
Shri Priya, am I seeing you in the next half an hour?
Yes, of course.
Okay.
I was going to say that if maybe many of the participants, they might come to a rest or end after this session. But of course, I will not be leaving Dr. Rajam behind because I am planning to be with her till at least 8:30 p.m. today because she is going to jump into another session with us again.
Yeah, so I'm going to quickly grab my dinner and I will see you at 7 o'clock.
Sure, ma'am. Thank you so
Okay.
much for joining.
Bye.
Thank you for enlightening us. I wish
Thank you very,
Radha
very much.
again.
It's really a pleasure and privilege to have you, madam, today.
No,
And
we
they
should-
had the
we
best
should all meet in
opportunity.
person. I don't know when that's going to happen.
That's what. Hopefully we will.
Yeah, hopefully. God
Thank
if
willing.
you both get the meeting at Parliament, that would be a blessing for us as well.
Where do you stay, Radha?
At present, I was with Pallium for 4 months. At present, I'm back in England.
Oh, that's why
I
you're wearing
was in
warm clothes.
Trivandrum till March.
You're wearing warm clothes. Okay.
Thank you.
Bye.
Thank you. Thank you.
Thank you,
Thank
ma'am,
you,
for
everyone.
joining us. Thank you,
See you
everyone,
all
for
next
joining
session.
in. As you have already heard the faculty, your feedbacks is important for us as well as the faculties because we need to keep improving our sessions so that we can also ensure that the correct information reaches every person who is going to practice or is practicing palliative medicine across the globe. So please do take out time to leave your feedbacks as well. And with the promise that we'll be continuing our session the next day, on Wednesday, with focus on wound management. This is Sri Priya, along with Dr. Rajam Iyer and Dr. Radha Venkatesh, signing off from the Tips Eco Hub. See you on Wednesday. Till then, everyone, take care. Bye-bye.
Thank you.